That's excellent. We're in full screen now, Govinda. That's great.
You're in full screen there, yeah?
Yeah.
Excellent. Thank you. Okay, so good evening all. Thanks for attending today. As I said, I'm Govinda. I'm a pharmacist and medicines management pharmacist within CGL, part of the pharmacy team. We're a small team of 3 pharmacists and a director. And today we're going to be talking about the new Core Mat pharmacy service, which is launching within Lancashire, across Lancashire, on the 1st of April. So thank you for all of you for attending. Obviously, I appreciate you've got Pharmacy First going on as well, so I know you're incredibly busy. And thanks in advance to the LPC for helping us support with launching this service and getting this service off the ground. The agenda for today's presentation is why change, Core Mat service, the aims and components, and I'll be looking at the individual components within the Core Mat service around wellbeing support, missed and late dose notifications, supervised and non-supervised claims, pharmacist-based reviews, and we'll look at the activity fees and then some discussion about training and assurance, and then open up to you guys for some questions, and there'll also be some feedback that we've had from the pilot sites that we've been running the scheme over the last 11 months now. The presentation will be around some evidence of what we found in the establishment of the scheme in other areas, and then how that relates to how we are today. And I'll go through the individual farm outcomes templates for you guys as well. There will also be a farm outcomes guide, to step-by-step guide on how to report on farm outcomes, and that should be coming through from the individual services in East Lancs and North and Central Lancs to you guys as well. I think that's going to come through the LPC, as will the SLAs come directly. So just a bit about myself. I've been a pharmacist for many, many years. I've been in substance misuse for the last 10 years, both in liaison and as a prescriber. I've also been a contractor, and I've also worked as a local and a pharmacy manager for the multiples. So why change? Most of our services involve prescriptions, as you're well aware, and they're dispensed by you guys as our community pharmacy colleagues, and therefore it's vital for us to have those good relationships and good links with individual community pharmacies and their representative organisations to ensure that we're working smoothly with each other. And as an organisation, CGL are aware of the stresses that community pharmacies end up with. We're very well aware, and with this in mind, we looked at alternative methods of having local services through community pharmacies, and which is where Core Mat, the thinking around Core Mat, originated from. Obviously, nationally, places like organisations like OHID, the Office of Health Inequalities and Disparities, is aware of the issue as well, and all substance misuse stakeholders are also aware of the issues, and we're all looking at how we can change the way we are having pharmacies run services on our behalf, and the remuneration around that as well. And so that's where Core Mat sort of originated from. Obviously, there's some recent guidance from OHID as well about delivering services for substance misuse through community pharmacies as well, and this sort of fits in with that new guidance as well. And obviously for us, what we get out of direct supervised consumption in terms of information quality is limited, but it does assure us that a service user is getting a particular dose at a particular time from a particular pharmacy. So we've got that reassurance around dose adherence. The new service has been developed with close cooperation with commissioners and LPCs from where it's been launched, and standardised supervised consumption model has not changed for many years. It has been the same as long as I've been aware, as long as I've been around, which is quite a few years, and there's been no real change to it. And the issue that we found is that obviously those service users that are not on a supervised dose are not getting any benefit from a pharmacy-based service. and the majority of our service users are not on a supervised dose. And at the same time, the support that you guys are giving on a daily basis to all service users is not therefore measurable, because we've got no means to measure it. And there is, people consider that the supervised consumption scheme is a transactional scheme. You measure out a dose, a service user takes a dose, and that's it. That's the extent of it. So we want to improve the quality and the efficiency of both working within the community pharmacy and how we work within services, and also getting that extra information that can safeguard, excuse me. Sorry about that, guys. So we want to get that extra information so we can safeguard service users going forward. And at the same time, we acknowledge that the remuneration around supervised consumption has not changed much either. So it's to improve that remuneration, and with that, increase the engagement that we get from pharmacies. So the aims and components. The vision that we had was a holistic approach to enhance the health and well-being of individuals affected by drugs, manage the risk, particularly around overdose, deaths, and other threats to health, and a quality-driven service with a framework which underpins it, so that we have the same framework operating across the country for our CGL services with this particular service through community pharmacies. And the components of the core map are wellbeing support, the reporting of all missed and late dose pickups, which I know you guys are already doing at the moment, supervised consumption, and a holistic review undertaken by community pharmacists. And like I say, it's to give equity to all of our service users, so that all service users are benefiting from a pharmacist interaction, and enhancing the safety of service users by having the missed and late dose pickups, promoting service user engagement with their treatment plans by having that conversation with a pharmacist based in a community pharmacy where they receive their medication, and looking to improve the general health of service users, and at the same time trying to reduce the workload on pharmacists by the way we report things. So the service has been active since last April, across 6 CGL services, covering roughly 5,000 service users, which equates to 5% of all service users in structured treatment across all services in England, and it's utilising 540 pharmacies. And what we found was that we retained all pharmacies that were originally in the supervised consumption scheme were retained into the new core mat scheme, but also we had an increase of 5% in participating pharmacies. So we've got some new pharmacies as well, which is very important in the current climate with changes in pharmacy ownerships. Some pharmacies are closing, so that was quite important to us as well. We had an extra 3,600 service users within those 6 pilots that were able to have a pharmacy-based intervention. And that was what our main aim was, is that everybody has equity to a service, a measurable pharmacist-based intervention. The current supervised consumption rates for those areas would have been 1,250, whereas now we're applying the access to a pharmacist across 5,000 service users. The average spend for pharmacy-based supervised consumption stroke core mat scheme increased from 6,000 to 10,000 per month for our individual services. Obviously, that's a reflection of how pharmacy remuneration would have changed as well. So it's an average of 66% over the previous supervised consumption model. There was a reduced time spent by both pharmacy teams and service-based teams on dealing with missed and late dose notifications. Obviously, with missed and late dose notifications, we have different ways of them being reported in different services across the country. So we wanted to sort of streamline it as well, because we've got some services where people will call, some places will have a direct line for reporting missed dose notifications, some places will email, some places use farm outcomes, as you guys do at the moment in across Lancashire. and we had a reduction in time taken to process these missed dose notifications across our admin teams as well. And we also carried out of our pharmacists in the 6 pilot sites, carried out over 1,000 pharmacist reviews in a 6-month period. So in terms of community pharmacy engagement, as I just mentioned, so we increased the number of pharmacies that were on the core MAT scheme as opposed to the supervised consumption previous scheme, from 515 to 540. So it's an increase of 5%. And we also have, I know in East Lancashire, we have Jane, who is our community pharmacy liaison lead, which some of you will know. And there's also a dedicated community pharmacy lead also across North and Central Lancashire. So they're very vital to us to promote that relationship between CGL services and you guys as individual community pharmacies. And please utilise at all stages any issues, any questions. Please come to us. Please raise it with Jane. Please raise it with Tristan, and we can pick up any issues and any queries that you have as you go along. We encourage all pharmacies, so not just the current pharmacies that are on the supervised consumption scheme, but all pharmacies to consider signing up for the core MAT. Because it's not just purely on, like I just mentioned, on supervised consumption. So it's the enhanced services that we're giving, in addition to just supervised consumption. So first stage of the first component of the core MAT scheme is the wellbeing support. This is something that you guys as pharmacists and your teams do on a regular basis. So it's just providing that appropriate advice from a trained member of staff at the request of a service user. And it's looking at things like harm minimisation advice, healthy living advice, signposting, referring, safeguarding, and that's all part of your current contract and within your healthy living pharmacy aspect as well. And for us, it's looking at things like safe injecting, giving advice on overdose prevention, healthy living advice, healthy eating, exercise, smoking cessation advice, alcohol awareness. And if there's any of those issues that you feel that your staff could do with some further training, please let us know, and our services, we can provide that training as well to upskill your staff. Second component is the missed and late dose notifications. So I know you guys are currently reporting missed and late dose notifications. The idea of the notifications is missed and late, and within 1 working day for reporting, and all service users being reported. So whether they're supervised or non-supervised, it's that information that we require within our services, because we base our treatment plans around risk, and adherence is the main concern for us. Obviously, World Health Organization has given information that there's potentially 50% adherence to service user medication generally across all patients. But for us as treatment services for substance misuse, it takes on an additional risk when a person does not collect their medication. And we need to be intervening as soon as possible to prevent them from falling off prescription, and also to prevent the risk of use of illicit drugs. And just around that issue, I mean, there is a potential drought of heroin coming to this country later on this year, because Afghanistan has reduced its heroin production, and that's where our main source of heroin is. And also we've got the new issue of synthetic opioids, which are the unknown, because we do not know what the actual opioid is, because it's manufactured in some illicit labs somewhere around the world, and there's talk of it being, some of them being 1,000 times more potent, like nitazines. It's an unknown, and that's even more important for us to ensure that all service users are adhering to their medication, so that we can safeguard them and make them safe. So that's the reason why missed and late dose notifications are important to us. They also support us and myself as a prescriber, so we can see where somebody is with their treatment plans, whether they're adhering to their medication and the risk that brings, and encouraging them to adhere to their medication, and providing them with the advice if there is any issues or any hindrances to them taking their medication on a regular basis. And like I say, it also triggers for the key worker to step up the input and the work they do around that particular services if there is a risk of them falling off prescription or if they're not adhering to their medication. And within reporting it within farm outcomes, it gives us that assurance and a standardized approach across our organisation. And it's also been registered in many cases with OHID and with coroners around concerns about the lack of reporting of missed and late dose notifications and the lack of, you could say, follow-up work that's done by services within substance misuse fields of how they respond to those missed and late dose notifications to safeguard the service user. Because in all eventuality, once it gets to the coroner's court, it's gone too far down the line. So that's what we need to prevent. So I'm just going to walk you through the missed and late dose notification template, the new one under the core mat. It is a pretty simple process. We've kept it as simple as possible and the minimum amounts of clicks. So it would literally just be selecting the date, selecting the service user, the drug, and then the subgroup within the drug. So if it's buprenorphine, then it's whether it's Subutex or Espranor, and then whether it's a missed collection or a late collection. And that is it. That's all that we ask. That then will go straight to our secure email. We're one of the first organisations that are non-NHS that have got interoperability with farm outcomes. So all notifications are received by CGL, the relevant CGL services. And then from that, they will go into the service user's case record, and a notification will be sent to the key worker to prompt them to make a call to the service user to see where they are, how they are, do a welfare check, and to ask the relevant question as to why they didn't collect the dose. In the next couple of weeks, it's also going to be going to a direct notification to the service user via a text message for those that have got consent for a text message. So we've got 88% consent for text messages from service users. So when you as a pharmacy report a missed dose notification, that will automatically trigger a text message to a service user as well to say, we believe you have missed a dose, please call the CGL service as well. So it's whatever we can do to engage that service user with their MAP medication. So in the evaluation from the 6 pilot sites, we had a doubling of pharmacies that were reporting missed and late dose notifications. And also we had up to 800% increase in notifications of missed and late dose notifications from services across 4 of the services. There was 2 services where there was an established paid missed and late dose notification system set up via farm outcomes. But even with that those 2 particular services, we still got a 20% increase in these notifications. And you could see in those areas where the missed and late dose notifications were working well across these 6 pilot sites, the need for restart appointments, which is normally a sign that somebody's disengaged with their prescription, had gone down drastically. And like I say, it includes for the first time supervised and non-supervised service users. So a late dose, it's just flashed up here. A late dose would be anybody that's collecting on an instalment prescription that's not a daily pickup. So for example, if it's 3 times a week collection and they don't go in on a specified day for their instalment, but they go in the next day, that will be classed as a late dose. Supervised and non-supervised. So within the scheme, all service users will need to be registered, not just the supervised. So there's a separate registration template, which is what you've got now anyway on farm outcomes, but we require you to register all service users that you have at your pharmacy. Supervised consumption still remains the core of the scheme. And we've also changed the terms of who can actually supervise. So it is any trained and competent member of the dispensing team. The previous SLAs mentioned a registered pharmacist or a registered dispensing technician. We've done away with that. It's now a trained and competent member of the dispensing team under the supervision of the registered pharmacist and within the skill mix of the dispensing team. So that is for you guys to select who is suitably trained or train them yourselves, as long as they know the mechanisms of the SOP of supervised consumption within your pharmacy and the SLA of CGL. There's also a simplified single data entry per service user on pharma outcomes to claim your end of month supervisions. And that is just a single entry. We don't ask for the daily entries to be made as you were doing at the moment for the 14-day scripts. And I say it's registration for all service users, and the monthly declaration that you do is for all service users, supervised and non-supervised, because the non-supervised are still getting paid the monthly activity fee for the missed and late dose notifications. So in terms of registration for you guys, obviously because the core MAT templates on pharma outcomes are different to the the previous supervised consumption templates, you are going to, as a one-off, have to re-register your service users, all your service users, supervised and non-supervised, just as a one-off, because the data on pharma outcomes is not portable. So whatever you've already registered under the previous supervised scheme is not transferable to the new core MAT templates. We have asked pharma outcomes if this was possible, but they've said it's not possible at the moment. So from the 20th of March, all the templates will be live and the registration templates will be there ready for you to start registering. So if I can encourage you to start registering ready for the 1st of April, that would be great. So that's the standard registration. We ask you to use the personal demographic service to register your service users. The reason why we ask that is that we are, as I say, interoperable between pharma outcomes and ourselves and within the NHS, so NHS numbers, etc. And when it comes to missed and late dose notifications or the pharmacy reviews, if you search for your patient and register your patient through PDS, it ensures that there's no spelling errors or anything like that, or any difference in numbers, because if anything is different to what comes up in PDS, when it comes to our service user record, it won't directly register within them because the data won't match. So it has to be matching data. So we ask if you can do it through PDS, that would be great. So end of month declaration for all supervised and non-supervised claims is literally just selecting the date, selecting the month for each service user, selecting the service user, and then the drug that the service user is on, selecting whether they are supervised, and then entering the number for the number of supervisions if they are supervised. It will ask you if you've made a reported or missed and late dose notifications, and if you tick yes, it's fine. If you tick no, it'll come with a message saying, please return to the missed and late dose notifications and report the missed and late dose notifications for the month. Now, it comes up with that prompt. The only issue is that if you start reporting all your missed and late dose notifications at the end of the month when you're doing this process, the data is not as significant for us if we do not have the data on a daily basis, because we can't really act on it retrospectively further down the line if we've gone past the days that they actually miss their doses. I'm just going to go to the next slide because it's just entering number of supervisions. Were all the missed doses, late collections reported, yes or no? And if it's a no, this message will come up to remind you to do that. And then if you've dispensed for at least 10 days for a service user, whether that's supervised or non-supervised, if you dispense more than 10 days, tick yes, and that trigger off the monthly payment as well per service user. And just discuss the reviews. So we were doing quarterly reviews in the original core MAT for the pilot sites. So that was a review every 12 weeks. There were a shortened review, quite a concise review, looking more at a service user's MAT medication and their adherence, and then looking at the naloxone provision, and then any of the extra healthy living advice. We did over 1,000 reviews, which is 20% of all service users potentially had a review undertaken by a pharmacist. And from those reviews, we can see that 16% of service users reported an adherence concern with their MAP medication. 12% were on a suboptimal dose of MAP medication and using illicit drugs on top. And they're the two main focus groups for us, because it's optimal dosing. The idea of our treatment is that a service user is stable on their MAP medication and not using illicit opioids on top. That is the aim of treatment. And in terms of dosages, we will go higher and higher and higher and higher until we occupy and saturate every opioid receptor, to ensure that therefore any drug that they use on top is not having any effect. That's the basis of our treatment. We supplied naloxone, or made a referral for naloxone through community pharmacies on 109 occasions, and healthy living advice was provided to virtually all of the service users. And not only that, but there was some quite good instances where people were requesting for help with their mental health, people were requesting help for their physical health, particularly with COPD, and the pharmacist made the referrals to the GP or to the mental health team as needed. So we did get some very good results with that. The only issue with the quarterly MAP reviews was that the feedback from pharmacists was that they were too frequent within your daily working. So they requested it to be reduced, so 6 monthly to annually. And so we listened to the pharmacist, and then we changed it now to an annual review. So all core MAP existing sites and new sites will be just one annual review. So the new annual MAP review, it's a bit more detailed than the quarterly MAP review, but it's looking at issues around service users' adherence to their MAP, looking around issues of any other medication that they're taking at the moment and their adherence, or any lack of adherence and any issues raised there, highlighting any possible contraindications and drug interactions in your professional opinion, and reviewing safeguarding of service users around naloxone for overdose prevention and safe storage of their MAP medication, particularly if there's children in the property, etc., and providing healthy living interventions and signposting as needed, and also offering the service user the chance to ask any questions that they would like to ask the pharmacist. So the templates, I'll just run you through the templates as well on those. The first two questions are around consent. So obviously the service user needs to consent to the review, and also needs to consent to sharing that data with us as CGL. If the service user declines either of those, then the review is ended, because we need that information for ourselves as well, and the service user needs to consent themselves for the review. On the issue of SCRs, we've made the template SCR capable, so there will be a tab for you, if the service user consents to access, for you to access their SCR, to click on the tab and you'll directly get a link into the SCR, and you can look at the SCR for the service user. And then it's looking at questions around any allergies that the service user may be suffering from, to document those if there are any adverse drug reactions previously, just to document those. And then it goes on to looking at their current MAP medication, and any issues that they have with their adherence to their MAP medications. So are they missing any doses? Is there any pattern to their missed doses? Is a service user saying that they're having problems with their medication? That means that then that's the reason why they're not adhering to the medication. It's looking at those sort of issues and documenting those, and looking at any other questions that might have around their MAP medication, that they feel they need more information on, and providing that information. It's not asking you to make any dose changes. It's not asking you to suggest any dose changes. It's just looking at their adherence to their medication. From there, we look at their MAP dosing, whether it's within the optimal ranges. So for methadone, it's 60 to 120 milligrams, and for buprenorphine, it's 12 to 16. And if they are on an optimal dose, then it's fine. If it's not, it breaks down into questions around are they using any illicit drugs on top if they're suboptimal, because that for us would trigger that we need to be upping the dose. We need to be encouraging the service user to titrate to an optimal dose. And it will also be looking at questions about they might be on a suboptimal dose but not using any drugs and stable, or on a reducing dose. We also ask you to look at their other medication that they're taking and the adherence to their other medication, and any questions they may have around their other medication. A bit similar to an MUR, but in a simplified form. And then in your professional opinion, if you feel there's any contraindications or any interactions, please document those. For us, around interactions, the main thing is if they're concurrently prescribed diazepam, if they're prescribed pregabalin. Obviously, they're all CNS depressants, so in combination with their methadone or their buprenorphine, that can raise issues for us. Sometimes when it comes to summary care records, we're quite good at getting them. Sometimes we don't get them. So this is an additional source. All this information is additional source of information from a fellow health professional, and the relationship that you guys have with service users is different to the relationship that we have with service users. So we can use that different information and amalgamate it, and it benefits us within our reviews and safeguarding of our service users. The next stage will be to make sure they've got naloxone. I'm not sure if any of you pharmacies are commissioned to provide naloxone. Then if the service user hasn't got naloxone, please provide it and record it on the pharma outcomes template for naloxone supply. If you're not commissioned, then please either refer to another pharmacy that is commissioned to supply, or refer them to CGL. And the same for safe storage. Safe storage is only accessible through CGL. So we need to ensure that every service user, we endeavour to ensure every service user has a safe storage box at all times to securely store their medication in their own properties. Obviously, in the past, we've had issues with child intoxication with methadone in particular, which is lethal in low doses as well. The last stage is just providing healthy living advice if the service user requests it, and documenting the advice that you give. And if you refer to any pharmacy-based services, such as if you do smoking cessation or EHC, documenting that, or if you signpost to anybody else, then documenting that as well. And then the last stage is just asking the service user if there are any other issues that they would like to raise. So in terms of fees, these are the fees that we will be paying. So it's £7.50 per month per service user across the board, whether they're supervised or whether they're non-supervised, and that's paid on a monthly basis. We pay £30 per completed annual MAC review, and then it's £2, £2 and £2.50 for buprenorphine sublingual, and then £2 for espranol and methadone. Obviously, there is a substantial investment from CGL within the fee structure. Like I highlighted earlier, there was a considerable uplift for pharmacies' revenue through the scheme, and I think you guys are currently being paid £1.65, £1.75, I think, for your supervision. So it's an increase in your supervision fees as well. The more you use the service, the better it is, because it will show us a reflection that the service is one, working, two, effective for pharmacy in terms of remuneration, and three, it's deliverable. So please engage with the service as much as you can. That's where we'll base our future services around. And in terms of training insurance, obviously we expect the pharmacists to be CPP trained and declaration of competence, and if there is a registered GPHC tech, to also be CPP trained and declaration of competence, and that declaration of competence for the pharmacist to be shared via Pharma Outcomes. As I said, we changed the skill mix, so any member of the dispensing team that's suitably trained and some of the pharmacists can undertake supervised consumption. Obviously, that will be down to you guys as pharmacists to assess who is competent within your pharmacy. There will be annual training events for the pharmacy team, and then there'll also be an annual audit, which CGL services nominated representative would attend each pharmacy and just have some basic questions around the SLA. So the standards will be around the SLA to ensure assurance and compliance within the SLA. On a monthly basis, obviously, we get our farm outcomes data reporting, so we will monitor the data as well and liaise with individual pharmacies and the LPC, see where we can support pharmacies where needed. And I'd say we put in considerable investment into this service, so hopefully we can see it take off across Lancashire as well, like it has across the other 6 pilot sites. And these are just some comments that we received from service users, CGL services, and pharmacies and LPCs in the pilot sites that we used. So yes. That's the essentials of the core mat. So it's like I say, there'll be a guide coming out on how to use farm outcomes for the service, and also give some information about what we're looking for within each component of the core mat service. I know it's a significant change to what you've been doing previously, but this particular service is the first of its kind within substance misuse arena. So others are looking at this to see where it goes, and that will be the basis of where future services from pharmacies are commissioned by all substance misuse services going forward. And it will also be the blueprint for us within CGL about how we then move with new services to community pharmacy, such as our core brief interventions and NSP, etc., etc. That is it from me. Thank you for listening, and I'll now hand over for any questions.
That's great, Govind. If you just want to stop sharing your screen, and what we'll do, if you don't mind, we'll go through the chapter questions first, because it might be a repetition, and then what we'll do, we'll open it up to the floor. So I think you've already answered Maxud's question to start off with during the presentation, but then we have another one just from Abid. The question is really around for a weekly collection, or those coming in twice a week. Would you not notify the missed dose daily? Would it be logged every day as late dose? So feel free to check on the chat function to reread that, Kulvinder, if you wish. It's in the chat function right at the very top. So that's a question for yourself, Kulvinder.
No, it's just the late dose. It's just the late dose. So it's the day they actually come in to collect the dose. That provides us with the information that we need. So, for example, if they're collecting once a week on a Monday and they don't collect until the Wednesday, we just need the collection. Then we just need to be notified that they actually collected their dose as a late collection on the Wednesday.
Thanks for that, Kulvinder. That's great. And then we got Anil as well. A question: what if the PDS, doesn't work? Doesn't find the service user? What do we do next?
Then you can enter manually.
There you go, Anil. Crack on manually. Yeah. Okay, yep. Then we got another one from Abid. So assuming an end of day daily log of collected missed late collections on farm markers is sufficient, and no further reporting via telephone for 3 days missed will be required. And also he's asking about a time restriction for this daily notification, for example, 9 p.m. We're talking about a late night opening sites, really.
Farm markers is open 24/7, so you can report whenever you want to report for that. So the reporting will come through to us. Obviously, it will get picked up the next day through the secure email. So that's fine. You can report as and when you feel. The sooner you do it, the better. But whenever you can do it within that 1 working day. Well, no, just simply the other bit.
It was just around the duplication. I think Abby's got his hand up as well. I'll come to it in just a second. But I think he's also asking about the duplication. Are we still going to need to contact, or actually is it automated? We've done our notification as a contractor, as a pharmacy team. There's no need to make contact via the phone.
For 3 days missed, we still encourage you to do it. 3 days missed, and also, obviously, if they're in a titration and you've got the specific wording on that is a titration prescription. If a service user misses a dose, please contact CGL services before you supply the next dose. So those will still be applicable, because if it's 3 day miss, the way farm outcomes work, it doesn't tally them up. So if you're reporting on day by day by day, yes, we should be able to get that. But sometimes Farm Outcomes doesn't always do that, as we've found. So what we would suggest, if it's a 3-day miss, still consider ringing the service, particularly like, for example, if they're on a 30 ml dose, they might not necessarily need to be retitrated because they're already on a what we would normally say a bottom end of a titrating dose. So we could still utilize the prescription.
And I think Abid, your question might be linked, so I'll bring you in. Abid, if you want to come off mute.
Sorry, just based on that question, in the SLA, it does say something about us logging daily as much as possible. Is that a requirement in the SLA?
Yes.
So for the ones who only collect once a week, twice a week, we're not actually making any. Are we logging Monday as a late dose, Tuesday as a late dose, or just the Wednesday as a late dose with no recording on Monday, Tuesday for the weeklies?
For missed doses, it's the day they actually missed dose. If they're on interval collections and they're collecting late on their due date, then you just notify the actual date of the actually attended to collect their late dose, if that makes sense.
Okay.
So the missed doses are more for the daily pickups or daily supervised. It's for those, and then the late pickups are those where they should be on a particular day and they're not collecting on that particular day. Because that will, for us, it might, if they're collecting, like for example, like for your Monday patients on a weekly pickup, and they always collect on a Wednesday, so keeping within the 3 day, not missing the 3 days, but they're obviously not taking the dose for the 2 days that they're not collecting. So that for us will trigger to see if there's a pattern in that behaviour. If they're doing that every week, that's something we need to follow up with the service user.
That's great. Thanks for that, COVID. And then we've got a question from Alec, just talking about the naloxone provision. He's asking why can't we have that service here in this patch? And I think, if I'm not mistaken, I'm sure Jane mentioned something later on as well, saying we could be offering a home. So perhaps that's a conversation for us to have, Jane, regarding that SLA, because we're sort of prioritising. You probably gathered contractors and trying to get the principle of supervision and core max out the way, and then we'll probably start to look at needle exchange and also naloxone. So I think that is definitely on the cards. You'd be pleased to know.
Yeah, definitely. It's definitely something that we want to drive. Obviously, as Kulvinder alluded to, the shortage with the Taliban ban and the new synthetic opioids, the risk is massive. So the more people, the more organisation services that we have on board that's delivering and being able to supply take home naloxone, absolutely fantastic. But yeah, speak to me, drop me an email, anything, and I'm more than happy to chat through what that service level agreement looks like.
That's fantastic. And I think Alec is probably related, so I'll bring you in, Alec, if it's related. Same question.
Yeah, absolutely. Very, very interested in providing the service as a complete care solution. So, you know, all those ones that run alongside it, if we can get them all working in one cohort or one contract, that's absolutely fantastic to offer. I'm obviously here representing Boots Pharmacies, and I'll just address the elephant in the room when it comes to Boots and contracts, and Jane and Dami will attest to this. It can take weeks or months to get a contract reviewed and signed and in process and in place. I can only apologise for how that is. Come the 1st of April, when the service starts, what happens if, for example, Boots hasn't got a signed agreement in place to participate? Will Farm Outcomes or be automatically changed to represent the new process, or will stores just carry on as normal for the time being until, as and when the contract does eventually get signed?
Could you come to us directly with that one, Alex? And I need to follow that one up with Mohammed just to check what the process. At the minute, the current templates for supervised consumption will be decommissioned from the 31st. Obviously, you still got your 2-month window to put your claims through for those, but you won't be able to register any new claims on those templates. Yeah. So come back to Jane and myself, and we can pick that one up. And I can just run that by Mohammed to see what we do about that. Yeah, come back to us on that one.
Will do. Thank you.
Thanks, Alec. I think we've got from another question there from Sanjeev. I think you've actually got your hand up as well. Should we just come straight to yourself, Sanjeev? You'll probably run through your questions as well. We may have just lost him.
I think we're looking at the chat.
Hello, can you hear me now?
We can definitely hear you about 10 times. We got a fantastic echo there. Mr. Patel, you'd be pleased to know. So, yeah, fire away.
Basically, I'm just trying to find out if CGL can provide IDs to all your clients for you when you're sending it to a new pharmacy.
We've got a bit of an echo there.
I don't know what's
Sandy.
okay here.
Let me see if I can mute everyone. We'll just try one more time. Give me 1 second. Okay, if you unmute yourself and let's give it one more shot.
Yeah, I'm just trying to find out if CGL can provide IDs to your clients.
Govinda, you're just on mute. If you just come off.
So obviously, Jane, if you can come into that one. But in terms of, we don't provide ID ourselves because we don't have any actual ID ourselves for service users. So we can give passwords or something like that. Particularly, we've got no way of making IDs. All we can do is provide descriptions for service users and also give a password that the service user would bring themselves. I mean, some people do not have IDs, and especially in substance misuse, we just have some people that do not have any ID whatsoever. And that's something that we deal with on a regular basis. There's not many across services, but in the past, where I've worked in Coventry, we used to use passwords to be given to the pharmacies, and service users would give that same password as well. But we don't actually produce any IDs or have any ability to produce IDs ourselves. I think you got a question in the tab about annual reviews. What if the client leaves after a few months? That's fine. It's a particular review to be done on a particular service user who uses your pharmacy, so that's fine. So we appreciate if they move from to a different pharmacy, then they can have a review at the other pharmacy as well if they need. But 9 times out of 10, if they've had a review once, they'll say they don't want another one. And does CGL doctors not carry out reviews? Yes, we carry out reviews every 3 to 6 months on a regular basis. So this is not pharmacists doing the reviews on our behalf. Our reviews are a lot more intense and a lot more detailed. This is a capture of their service user adherence and any issues that are picked up within the pharmacy on their adherence and any issues with their dose within the pharmacy with their MAP medication, and also holistically looking at their safeguarding with naloxone safe storage, offering them healthy living advice, which we more than likely don't do, apart from if it's related to bloodborne viruses and things like that within services. We don't have the sexual health clinics. Some places do, some places don't. That would be externals coming in. So we don't offer all those sorts of services ourselves. We offer food, but we don't probably offer healthy living advice from within services. So it's a different review. It's a more of an adherence and any issues that come up review, and also any issues with their current prescribed medication from their GP or any OTC medication from that they're buying themselves review within the pharmacy field.
That's great. Thanks, Govinda. I was just going to say, is there any further questions, Sanjeev? Do you want to come in again?
I'm not happy about your answer on IDs, really. Why can you not take a photograph and just print it and give it to them with your signature or a stamp?
We can put that through to Jane. Jane, if you can raise that within, or you can raise that within your services, see if that's something that you can do.
Yeah, well, I would like you to do that. And also, we need dedicated telephone numbers, because Inspire never pick up.
Obviously, in terms of notifying about dosages, and that's why we've got the Pharma Outcomes platform for missed dosages. And but yes, we can look into that as well to see if there is a dedicated line that we can do, or a dedicated email.
I will drop my email in the certainly in the chat, and if you are having difficulty contacting any of our services, then please let me know, because I'm always more than happy that you can have my direct number, and I will look into why the phones aren't being answered. Because I do appreciate sometimes lines are very busy and vice versa. But certainly I'll put my email in the chat if there's any problems.
And also now on the new phone system, there's an option to go to the prescribing admin team, and that plays a message with a direct email address as well. So if you can't get through, you can go through to voicemail or email. So that should help with that as well.
That's great. Thanks, Jane and Tristan as well. Nice to have you on tonight as well. Okay, if we go on, we've just got one more, which may have been answered, but to Maxud before we go on to the floor to Vipul. So any guidance on when we should not supply, i.e. 3 days or more rule still applies?
Yep, that still applies. And also, like I mentioned earlier, about if there's a missed dose within titration.
Much appreciate. Okay, across to Vipul.
Hi guys, just a quick question. One of the templates that you had out there was to fill out the prescription on a monthly basis for collection. The prescriptions don't finish on day 1 to day 28. Do we sort of, if we start mid-February, for example, do we fill it out from February till the end of February, then carry on in March?
Yeah, so it's obviously with the old system, you loaded up the 14-day prescription and you worked it from that. So this is the doses that you supervise or the service users that are collecting with you that are non-supervised within that month only. That's it.
And so would we get paid, let's say if prescription sort of is 14-day script, it's 7 days supervised, we'd get paid for that 7 days in February and the balance of the 7 days in March, for example. Is that correct?
Yeah, yeah.
Okay, thank you.
Thanks, Vipul. Right, we'll open it up to the floor if anybody wishes to raise their hand for any additional questions. Okay, we've got a couple of more hands up now for you, Kovinder. So we go to Shahid first.
Hi, if we don't currently offer the service, then how will we sign up to it?
Through the SLA. So if you let Jane know, depending on which area, or Tristan know, and we'll send you the SLA.
And anybody on the call, if you want to any query like that, come straight back to us, office@cplsc.org.uk. Any co-associates, any additional pharmacies, come back to us and we will liaise directly. I think we've got the full crew on. We've got Jane as well. We've got Kovinder. We've got Tris on. I think I saw Demi as well. So I'm sure we'll get it across the right location and we'll get you set up and started. We're very, very keen on this holistic approach to try and support this particular patient and customer group. Does that help, Shahid? Any further questions?
Yes, thank you.
No problem. I think, Sanjeev, you've got your hand up again.
Currently, we still have to pick up prescriptions from Inspire in Preston. And our drivers having to wait 15-20 minutes minimum. What can be done about that?
Tris, can you?
Yeah,
pick
I'll
that?
look into that. 15 to 20 minutes. Is that every week?
Every week.
Okay,
And
I'll look into.
and there's no parking, as you well know, in Preston.
Yeah, which pharmacy? Sorry, is that?
Avenham and Moore Park.
Okay, I'll look into that.
Okay, thank you.
Thanks.
Thanks for that, Sanjeev. Okay, we've also got Maxud. Hand raised. Over to you, Maxud.
Yeah, I just wanted to clarify. One of the slides mentioned something about 10 days. The client has to have been with you within 10 days or had at least 10 encounters. Can you just clarify that? Does that mean that if they've been to us for 9 days and then they go to another pharmacy, we don't get paid at all?
So for the monthly activity fee, you have to dispense 10 days worth of medication. That doesn't involve the supervised. That doesn't involve the supervised. So your supervisor will be supervised as normal, but for those that are non-supervised, it's a 10 days or more for the monthly fee. So the monthly fee will be paid to all service users, whether they're on supervised or non-supervised, as long as they're with you for 10 days. Not 10 interactions, just 10 days worth of supply.
Okay, that's fine.
I think it's
Thank
to
you.
prevent the transitional sort of movement, acute, going from one place to the next.
Yeah.
A bit of a protective measure, because of course this is a financial envelope which actually comes from the council as such, and CGL then obviously therefore third-party commissioners. So you can see it was quite a complex arrangement for the last 9 months. We've been working on this. There's about 9-10 different cohorts of changes to the SLA as well. It takes time. And of course, this had to be approved directly by the council, which, as you know, are cash strapped, just like the ICB are. So we're very pleased that we're at this stage. So I will open it up again for any final questions. But just for note, everyone on the call, once we sort of end, roughly the plan was almost now for 8 o'clock, we will have the next 10 or 15 minutes for contractors in particular, or representatives of the contract in question. We'll have a closed confidential session just for contractors, for anybody who wishes to ask very specific queries to ourselves at CPLSC, if that's needed, of course. So just after this sort of session closes and no further questions, we will probably remain on the call, and we'll kindly ask the CGL crew to sort of leave and thank them for their evening session, and we'll continue any further questions and answers, specific or confidential, as it is. We've had a couple actually come through the chat. If I could, Kulvinder, we'll just go to them next. So I think Sanjay just asked the similar question on photo ID. Again, we've made a note of that, so we'll come back to you on that. So Ansar just asking, why do you prescribe by brand Fiseptone?
So we had fluctuations in pricing a few years ago. This is before my time of coming into this role. So the national approach was to prescribe by Fiseptone brand. It is reviewed on a regular basis. I can't really say any more about it because I'm not party to those decisions, unfortunately. I don't deal with that in particular, but that was a decision at the time, because at the time when buprenorphine was fluctuating, 2018, 2019, at the same time so was methadone. And as an organisation, obviously the drugs bill is our biggest bill, and within that then affects the money that we've got for other resources.
Thanks for that, Kulvinder. Maxwell, I think you've also got your hand still raised. Is that a historic or another question? Okay, that's dropped. Thanks. I think we've got something else in the chat just come in. Might be Ansar again. So change back to generic. Simple as that. No messing about. So change back to generic. It's all stable now. Plus, generic is cheaper than the brand. And of course, there's implications of margin for contractors. And we have gone through that at length. And we have, and we'll still continue. We have done for the last 8 months, not just with CGL, but other providers as well, on a contractor perspective. Oh, okay, I think we'll probably end sort of proceedings at that point. Could I just thank Kulvinder and all the rest of the CGL team on tonight? And I'm sure it'll be a chase for the SLAs moving forward. Could I just confirm, have those SLAs directly from the commissioner gone to the current providers, or is that still to be released, Kulvinder? Do you know?
I default to Jane and Tristan on that one.
No, we haven't done anything yet at this moment in time. We were actually waiting for tonight, but now it will be all systems go, which you will start to see within the next week or two, those SLAs that will be getting sent out by the normal channels that we do. And again, any questions, by all means, message
Jane.
myself, Tris, or Dami. The
Jane,
details.
Sorry, Jane, I'm jumping in then. Jane, can you make sure the guide goes out as well, the farm outcomes guide
Yes,
as well? Thank you.
definitely.
Fantastic. Thank you very much. But just for the contractors on the call, we have sent out the draft versions for your review ahead of tonight, and to allow for the next session. And of course, you'll have that available until that comes through by the commissioner directly from CGL. Okay, on that basis, I shall just stop recording. I shall bid you all a good night. Thank you very much for your support. And any contractors who wish to stay on, please do so. And we'll continue any question and answer specific for us. Thank you very much, Kulvinder and team.
Thank you, Mubashir.